Memorizing a chaotic wash of raw, underwater-like cardiac audio from a patient makes accurate diagnosis feel nearly impossible. Accuracy requires looking past the sound to visualize the mechanical pump physics creating the noise. True auscultation mastery involves transforming abstract acoustic signals into clear mental pictures of anatomy and fluid dynamics. This diagram shows the geography of the chest. Think of the broad torso as a shield, with the central sternum acting as a fixed, vertical measuring ruler to map out the horizontal rib spaces. Auscultation relies on sound projection rather than direct anatomical placement, as the heart valves themselves are buried deep beneath the ribcage. As blood forcefully exits a valve, it carries the vibration forward along the pathway of the bloodstream, striking 4 specific listening points on the surface of the chest. Knowing where to listen is only the first step. The real diagnostic power comes from understanding the mechanical forces creating the noise. This schematic visualizes baseline heart sounds. Panel A shows lub, or S1. This marks ventricular contraction, when pressure rises fast enough to force the mitral and tricuspid valves shut. Mechanically, it's like 2 heavy doors violently slammed by immense pressure behind them. Panel B illustrates the dub, or S2. As contraction ends, arterial blood briefly tries to reverse, creating a backflow swirl that catches the upper aortic and pulmonic cusps. That swirl snaps them shut, exactly like a liquid wave washing backward into swinging saloon doors. The standard lub-dub provides the baseline acoustic signature of functional pressure doors closing in sequence. When the doors work fine, but the physical muscle walls of the chamber begin to warp, the sound shifts. Panel C shows the S3 splash. This occurs during the rapid passive filling phase, when excess blood rushes down into a dilated, floppy ventricle. The volume overload hits the distended wall, creating a sloshing oscillation, much like jumping onto a fluid-filled waterbed. Panel D shows the structural opposite, the S4 thud. An atrium forces blood into a stiff, thickened ventricle that refuses to expand. The sudden deceleration creates a vibration, like throwing water against a solid brick wall. These extra S3 and S4 sounds serve as acoustic warnings that the heart's structural architecture has shifted. Murmurs provide the distinct acoustic profiles of broken valves, failing to hold back high-pressure fluid gradients. This chart in Panel H shows mitral regurgitation. The valve fails to close completely, allowing blood to leak backward throughout the entire contraction. Because the pressure gradient remains constant, the audiograph is flat, sounding like the unyielding hiss of a leaking pipe. Contrast that with aortic stenosis in Panel G. Blood is forced through a stiff, narrowed opening, causing flow velocity to peak in the middle of the contraction and building a distinct mountain shape on the graph. Other deformities create equally specific profiles. A stiff mitral valve popping open under pressure sounds like a rusty gate, while floppy structural cords pulling tight create a sharp click, like a heel snapping on tile. The shape, timing, and pitch of every murmur perfectly mirror these distinct hardware failures inside the pump. Look at this final memory panel to review the visual map. Door slamming shut, waves catching saloon doors, waterbed splashes, brick wall thuds, rusty gate pops, mountain flows, and leaking pipes. When a physician places a stethoscope on a chest, they are using these auditory cues to reconstruct the heart's internal fluid dynamics in real time. Translating that acoustic vibration into a visual map allows for an assessment of the heart's structural integrity without a scalpel. Armed with this mechanical decoder, you can look past the heartbeat's noise to see the machine.